let's talk about Sacituzumab Govitecan if we can. Sacituzumab Govitecan is a TROP-2 ADC. We're putting it second on the list because it is used in the United States. It has FDA approval of a 120 patient study. I believe you were leading that study, Petros. It's a response rate of, I think it's 28% in the updated. It's 27 here. This was the earlier study. 34% response rate with immune checkpoint inhibition, but that was that's second line, not first line.
41% with the new data cut, 41% Saci plus Pembro, platinum refractory second line.
41% there. And then, so that's an updated on this, 41 from 34, so that's higher. It's not 70%.
You're right. It's not 70. It's 41%.
So it's 41.
But it's platinum refractory second
yeah,
line.
No, I did say platinum refractory, and then we got the neoadjuvant 4 cycles of single agent Sacituzumab Govitecan. Again, it's one of these neoadjuvant trials. I spent a lot of time on this. I find it hard to interpret. 7 of the patients had a clinical CR but didn't have surgery and therefore may or may not be a CR patient. They counted them as CR patients in some of these. It's complicated, but it looks to be active. But there were 3 treatment-related deaths in that. So the question to you, Petros, is where do we go with Sacituzumab Govitecan? And of course, we know the TROPiCS-4 trial is negative. That's the randomized phase 3 study of Sacituzumab Govitecan versus Taxol chemotherapy in PD-L1 and chemotherapy pre-treated patients. I think many of us hoped and expected that to be positive because Taxol chemotherapy is not incredibly active in this disease, and not being able to beat that. Is that a problem, Petros?
So first of all, I think it's great to have options for the patients, and we all encourage drug development in the field. I think TROP-2 is a relevant target. It's significantly expressed in urothelial carcinoma. As you mentioned, Tom, 28% response rate with SG monotherapy. This was a heavily pretreated patient population with a median lines of prior therapy between 2 and 8, so a very heavily pretreated population. Obviously, this can impact response rates. The combination, of course, you mentioned it, 41% response rate with Saci Pembro. The TROPiCS-04 trial data will be key to see. I think will be important to see the granularity of those data, look at survival at both arms, and also look at the issue of growth factor support, which in my opinion is a very important one. I cannot say whether it can explain a big part of the issue TROPiCS-04, but I think it's a major issue across the
So you
trials.
say the drug has activity, but you're concerned about the toxicity. Is that fair?
I think it's a fair statement, a summary statement, and I think
Carla, your
primary
hands
prophylaxis is key with growth factors.
Carla, then Shilpa. What do you make of the Sacituzumab program in the knowledge that we don't know the TROPiCS-4 results?
Fair. So I'm going to push back a little bit on your comment about taxane. So we did a study just before immunotherapy came along, a second-line study of Abraxane versus paclitaxel, and response rates were sitting at around 23%. It was a negative study in that nab-paclitaxel didn't do better, but response rates were around 23%, which is about 15% more than we think taxanes actually have. So I use that sometimes late line when I don't have anything else. So if you combine that with the fact that there is risk of toxicity and neutropenia with Sacituzumab Govitecan, and there was some dust, I don't know that I was that surprised about the TROPiCS data, to be perfectly frank.
You weren't surprised.
I wasn't that surprised.
So I feel the bar's a bit low, but Carla's saying it's a little bit higher. So, Andrea, where's your take on this drug? Is this an important drug for us, or is the fact you can't beat docetaxel means actually in the end it's not a game-changing agent? Where are you?
So EV plus Pembro is not 100%, right? We still have patients that are refractory. We have patients that are then refractory to platinum. What do we have next for them? Taxol, okay. But then what next? So if they're FGFR3 positive, or fitness, but I think we need more drugs that are effective. This is a therapy that works. There's toxicity associated with it. It needs to be given correctly, but I don't want to lose a therapy that works for patients.
So you would like the FDA not to withdraw this?
I would.
You would like them not?
I would like them not to withdraw it.
Shilpa, where? Because I'm a bit European, actually. I still feel very European despite that Brexit fiasco, which...
I'm European too.
Yeah, well, Petros, yeah, but you're a proper European. I feel sort of half European now. I feel sort of stuck in the middle of the Atlantic somewhere. From a European perspective, many people say we don't currently have this drug, and if you can't beat Taxol chemotherapy, do we really need it? Like, we had ramucimumab. That beat Taxol chemotherapy for PFS, but not OS, and we never took that one forwards. And so why do we feel What's your take on this, Shilpa?
Yeah, my take is a little different.
Is it alive or is it dead?
Yeah, my take is different. Yeah, we saw activity in this single-arm trial, and that's why we do phase 3 trials.
Yes.
And if a drug cannot not only beat the platinums or whatever, Taxol or the salvage chemo, but is also more toxic than those agents, then I really don't see the need to have that, because it's really hard to explain to a patient that, yeah, we saw some activity in a boatload of patients in this, but in the large trial, it was actually not even better and it was more toxic. So I think we are getting to, in my hands, like I have not seen neutropenia with this because I give preemptive growth factors, but it was also not more effective. So I would say that, yeah, it's good to have it just in case, but would I really want to offer it to a patient? I'm not really sure.
So your take is you don't mind if the FDA were to withdraw this? Because they're going to have to make a decision. I think it was a provisional approval of a single-arm trial. This was the confirmatory randomized phase 3. There's no other randomized phase 3 out there. So the FDA is probably sitting with this right now, and it's saying, what do we do? And you wouldn't go to the FDA with a negative randomized phase 3, would you? I mean, you wouldn't do that. So they're there at the moment, and it's a difficult choice. And you think they should withdraw it or keep it?
Well, how
I think
negative
for
is
all
it? We need to see the
practical
data.
yeah,
the
we have
data,
not
the
seen the
data.
data, yes. But if it's there and patient has no other options whatsoever, are we going to expect them to live longer? That's probably not the case. So I would say I would love to see what the ODAC votes on that. Yeah.
Okay, we're good there. So Carla, we're here with a combination of SG and EV, different payloads, different targets, perfect dance partners, response rate out of the Dana-Farber of 70% with some toxicity. 73% according to Tony in the audience. Thank you for your continual interruptions, Tony.
23 patients, 70% response rate.
Who wants to take on Dad? Is this the future of Sacituzumab Govitecan in combination, or is this just a phase 1 trial that we're never going to be able to translate into randomized phase 3s?
I think this is exciting, and I think that the response rates, although a really small study, maybe this is a place for SASI, and maybe the follow-up, the DADDY-O, which I love that name, as the next study, combining IO in there, you may get some benefits there. I think it'd be interesting to know EV plus IO compared to the triplet.
We're actually opening a study following this data to corroborate this and validate it. We're going to have a study with EV plus SG plus a checkpoint inhibitor in the first-line setting. So we try to get a signal whether we can replicate the data. Of course, we'll do a stepwise approach, phase 1 first, establish safety, make sure the dose is correct, using growth factor support as primary prophylaxis for SG, as we discussed, and build with a potential triplet to see whether we go or no go to a phase 3 trial.
Okay, so there are other TROP-2 ADCs with topoisomerase payloads. Are all TROP-2 ADCs with topoisomerase payloads, are they all the same? There's DDXD, there are other agents as well. Does this mean there's trouble for all of these drugs, or should we be doing one at a time? The linker molecule is obviously extremely important. Shilpa, do you want to take that on?
Yeah, we have experience with other TROP-2 ADCs, for example, the Merck compound in the early trials.
Don't say anything that's not in the public domain.
Right, sorry. It's an ongoing trial.
Ongoing trial on clinicaltrials.gov.
Umbrella,
but
yes.
but don't tell the results.
Sorry.
Yeah.
No, there is no results, but
Okay,
in our experience, that is not showing neutropenia. So
Okay.
there are other TROP-2 ADCs without the same toxicity.